Hey everybody, welcome to our stream today. We have a fantastic program today with two very esteemed and wonderful clinicians. I'm going to bring on stage Dr. Robert Hamilton, who's the CEO and founder of Neurosignal. Robert, how are you doing? Good to see you.
I'm doing well, Omar. Thanks for having me.
Absolutely. So, Robert, maybe before we bring on Dr. Khan and Dr. Walker, give us a little bit of an intro about the topic we're going to be discussing today.
So today we're going to be talking about the importance of detection and diagnosis of PFO, which is a condition that we're all born with, but in 25% of us, it does not close after birth. And this actually, the presence of a PFO has an important indicator of stroke risk later on in life. And the detection of PFO is an important aspect of how we determine how a stroke was, why it occurred. And more importantly, how do you treat it down the road? So Dr. Walker and Dr. Khan have a very interesting approach and really groundbreaking work they're doing up there in British Columbia.
Fantastic. Well, let me bring them both on stage. So Dr. Khan and Dr. Walker, good to see you all. How are you all doing?
Good. How are you?
Doing well. And for those who are just joining, if you are getting settled in, go ahead and leave a comment what city you're watching the stream from. So Dr. Walker, Dr. Khan, where are you guys joining in from?
We're both at Royal Columbian Hospital outside of Vancouver, about 25 minutes outside of downtown. And it's one of Canada's largest hospitals. It's a University of British Columbia teaching hospital. And I'm a stroke neurologist there, as well as general and interventional neurologist. And together, Dr. Khan and I set up the regional PFO clinic and Stroke in the Young clinic.
Fantastic. Well, on that note, I was going to say, maybe Dr. Walker, you can start first. Also, give a little bit of background on your training and current position, and then Dr. Khan, you go next.
Absolutely, yeah. I was born in Vancouver. I did undergraduate studies at Williams College in Massachusetts, and then came back to UBC, University of British Columbia, for medical school, neurology residency, did stroke fellowship at University of Pittsburgh Medical Center, and then interventional neuro fellowship and transcranial Doppler training certification at University of Ottawa. And then came back to Vancouver to work at Royal Columbian and UBC.
Fantastic. And Dr. Khan?
So I did my med school at McGill University in Montreal, which is where I was born and raised. And then I went to Ontario to do my cardiology training in London, Ontario. And then I came back to Montreal and did my interventional training, both coronary and structural, at the Montreal Heart Institute. So yeah, I work with Greg here. My predominant focus is on coronary and structural interventions, including PFO closure.
Fantastic. And we do have more people that are just joining us. Just giving a quick few shout outs. We got Madeline joining in from New York. We got Alyssa coming in also from New York. Hey, everybody. So while you guys are jumping in, if you're enjoying our stream and what you're seeing, just give us a like, hit the like button, and feel free to ask some questions. So that being said, let me take Robert and myself off, and Dr. Walker and Dr. Khan, you have the floor. So for everybody, we're going to go through a few slides. Feel free to drop your questions in the comments. From now, when you see the slides, or at the very end, we're going to have a Q&A. So Dr. Khan, Dr. Walker, the floor is yours. I think I'm starting with Dr. Walker's slides, correct?
Yes.
All right, perfect. Let me take me in. I'm coming back.
Load my talk. Sorry, almost ready here.
No, all good. Okay. That's what makes these things fun. You gotta have a little fun with these things. All right, there we go.
There.
We got the right one. All right, awesome.
You got my title slide there.
Perfect. It's all yours.
All right. So I'm a clinical associate professor of neurology at University of British Columbia, one of the biggest hospitals in Canada. Royal Columbian is a UBC teaching hospital, and about a couple of years ago, when I had finished TCD certification, started practicing TCD in the real world at a big, busy hospital in Canada, which had limited resources, I found that manual TCD was very challenging. But then serendipitously, I came across the robotic TCD NG2 model, which we'll talk about today. And that was really, career changing, life changing, game changing for me. Dr. Khan and I knew each other peripherally, but this really brought us together. Special thanks to many colleagues, including Dr. Naidu, Dr. Medvedev, Dr. Al-Sultan, Dr. Brar, Dr. Chen, these are stroke neurologists, and Dr. Shanks, Dr. Epstein, Dr. Lee, cardiologists, echocardiographers, and RCH Foundation. So the reason why I got interested in transcranial Doppler was really because I'd read a lot of the previous studies that discussed PFO studies in TCD as a way of looking at cryptogenic stroke. I was not aware that TCD for PFO was a common test back when I was in training, but I'd heard about transcranial Doppler. Of course, the manual version's been around for decades in neurology. And then as the ESIS trials came to fruition, but did not offer a whole lot of new insight into mechanism of stroke, I thought more about PFO and TCD. And then realizing that PFO is probably overrepresented in stroke in young patients, some of these questions started to form in my mind that with, at that time, manual TCD could be improved detection of PFOs, because there is a paper I'll review, a systematic meta-analysis. But then when NG2 came out, I realized not only detection, but shunt grading was much improved with the robotic NG2 that we'll discuss, and really started to get me thinking about a lot of these cryptogenic strokes in ESIS patients are probably just missed PFOs. Even in older patients, or patients that we consider older medically, greater than 60 or 65. So the main question was, how do we improve PFO detection significantly and without much trouble? Because in Canada, we're a resource efficient system. That's a nice way to put it. We are trying to look for ways to be more efficient and time-wise, money-wise, resource-wise. And so Dr. Khan and I got together with the NG2 and formed a PFO clinic, and really allowed us to collect a lot of real-world data about cryptogenic stroke in the young, ESIS patients, and what we call now between us is PFO medicine. So what I'll often refer to as traditional screening or echo-based screening, typically TTE, bubble study screening. Of course, this was a mainstay at our hospital for all our stroke patients. But then when we started to introduce the robotic transcranial Doppler in 2023, we found that this was absolutely game-changing for us, and increased our PFO detection significantly, therefore increasing our diagnosis of mechanism of stroke, increasing closures. And we found that one of the keys was the significantly game-changing sensitivity of robotic TCD for PFO detection, but also grading, which I'll review all of this. So yes, 270% is a big number. That might be hard to wrap your head around, especially with pretty much every stroke center in the world being echo-based. Although in Canada, there is several big centers that have the robotic NG2 and are shifting to our model, a PFO clinic, which is echo and transcranial Doppler, like robotic transcranial Doppler based. So I hope by now I have your curiosity and your attention. And so a tiny bit of background here. This is Mr. Reynolds here playing a physician, maybe local boy. So we're all very proud of him. Big philanthropist to the medical system and environmental projects in Vancouver. But here is a paper that really kind of gets the conversation going. There's a big Canadian flavor to it. Several of the authors are Canadian, and it was a systematic review from 2016 and meta-analysis that showed actually manual transcranial Doppler had improved sensitivity over transthoracic echo for detection of PFOs. So back in 2016, they were already on to this, that there's better ways to screen for PFO than just our traditional echo-based algorithms. So highlighted in yellow here, you can see this was manual TCD, highly sensitive, 96.1% sensitive as compared with TEE, which was the gold standard, and continues to be in this paradigm, but I'll challenge that as well today. And then noting there the poor sensitivity for transthoracic echo bubble study, 45%. And of course, not all echoes are created equal or echocardiographers. Here in this study, actually a very high specificity for TT. I can say that we have not encountered such a high specificity. We find a few false positives, especially at outside hospitals where they may not be doing the number of echoes we're doing at Royal Columbian. And then this was really game changing. I hope all of you are aware of the bubble study. If not, it was an absolutely phenomenal study that I think will, be a study that kind of improves with age, gains more hype with age, kind of like, a cult classic movie like Anchorman. But Mark Rubin and Alexandrov and Tom Devlin, these are big figures in the TCD world, and they showed that the NG2 robotic TCD that we use actually has superior sensitivity for shunt detection, specifically PFO detection. And when this came out, it was game changing for Dr. Khan and I because it allowed us to lobby our foundation to set up a PFO clinic. So that brings us to our hospital real world experience. It's a big, busy trauma, stroke center, neurointervention, neurosurgery, interventional cardiology. At times it's a very, chaotic place. It's the only hospital in British Columbia that has every kind of physician. So our maternity, maternal fetal medicine, neonatal ICU, pediatric services are all together in this very large hospital. So you can imagine we see and do a lot. We need something that's efficient and something that works. And that has been our experience with NG2. And Dr. Khan might speak more to this, but prior to starting the NG2 PFO clinic, we had, I think, that 2022, 9 closures that year. And then as we incorporated the NG2, we found more PFOs that we call culprit PFOs, meaning ones that need to be closed because they're related to the mechanism for TIA or stroke. And of course, this then led to significant increases. In 2 years, we almost doubled our closure rate from opening the clinic. And then, of course, more than tripled the baseline rate from prior to the clinic being formed. So a little bit of data. The way to conceptualize my part of the talk is we've shown improved detection of culprit PFOs, but also increased shunt grading for PFOs, which are both very important in terms of deciding whether or not a PFO should be closed or not for a patient. So some basic data, we had 156 TCD studies for PFO detection. And of course, the NG2, as TCD has many applications. And I've used it for many different things at our hospital, but of course, PFO is one kind of workhorse application. So 156 studies, 98 cases were positive, and these are all very highly selected patients. So these are patients typically seen by other stroke neurologists first. They've had a hypercoagulable state workup. They've had an atrial fibrillation workup, prolonged cardiac monitoring. These are highly selected individuals. So out of 98 cases that were robotic TCD positive, 35 were transthoracic bubble study negative, which I think if you think about that systematic review, that's pretty much in line with the literature meta-analysis. Concerningly, but also in line with the data, 17 of the 35 cases that TTE bubble missed were actually large shunts, so greater than grade 3. So that's pretty significant. So we essentially would have missed 17 closures if you look at the data that way. 5 of these 17 patients were TCD positive, of course, and transesophageal echo negative or non-diagnostic. So if you're thinking, well, why not just send everybody for a TEE? Well, that's not going to work. You're still going to miss quite a few cases. In fact, 13%. So that's a big take home. All right, now shunt grading, and this is maybe novel to our data set, other than there's a great paper by Dr. Ira Chang from Swedish in Colorado, I believe, but they introduced this idea of, well, if you're using robotic TCD for shunt detection, how does the grading compare to traditional transthoracic and transesophageal echoes? So grading, again, like all echocardiographers and pretty much in the world, nothing's perfect. There's always heterogeneity. So we took 19 patients in our data set that were TEE and TTE and TCD positive and had a very reliable grade reported. And we compared the grades between robotic TCD and the echoes, and we found that we had what's called a shift. If you're a stroke neurologist, you probably think back to the Hermes trials from 2015, 2016, the modified Rankin scale shift analysis. That's essentially what we did. So these 19 patients, if you use the Pascal score based on echo, you are going to not close 9 of them. But if you use the shunt grade of 3 or more on TCD, robotic TCD, all of these were going to be closed. And I'm certainly happy to answer questions on that, but we've called this a M-Pascal shift analysis. So the MS is modified screening. So we're using the robotic TCD to change how we screen patients. So what we're finding is in patients where an echo is noticed, where a PFO is noticed on echo, it's probably pretty large. And the robotic TCD fortunately grades 100% of the shunts. There's some secret sauce to it, but I'm not the only center that has had this kind of data. As mentioned at the bottom here, there's at the top here is Swedish. At the bottom is Tom Devlin, CHI, Chattanooga, Tennessee. And they've also experienced pretty significant increase in detection and closure. Also, Houston Methodist, 3 times more closures with the robotic TCD. Erlanger Neurosciences, 5 times more. And Sharp in San Diego, very high volume center, 2 to 3 times more. So we're not the only center that's noticing this skyrocketing of PFO detection for culprit PFOs. So that's, data from Houston Methodist. It's much similar to ours. This is the CHI and Erlanger. So this is the Erlanger data. CHI's data. So you can see their PFO closures are going up and up and up. Interesting, their 2021, very similar to ours, 2022, 9 were closed that year. And this is all with robotic TCD. So just a simple introduction of robotic TCD. So objective number 2, well, why is this working so well? Why are we experiencing this sort of skyrocketing, game-changing data? Well, we talked about one reason, TTE bubble studies are poor in terms of detecting shunting. But why is TCD so good and why is it not more common? Well, TCD done manually, one side at a time, if you've ever tried it or trained in it, it's extremely cumbersome. If the patient coughs or sneezes or if your hand cramps up, there goes the vascular window you're looking for. And the vascular window at the best of times is challenging to find in terms of the exact area to ultrasound and the angle. So it's a very challenging study to do technically by hand. And then, of course, the robotic ultrasound bilateral simultaneous ultrasound probes controlled by a robot find and within seconds typically where to ultrasound. So you get this great picture of color bands in an XY graph. And on the right here is what the robot looks like. There's a headrest, little black probe. So you can see my cursor. That's a little ultrasound probe there in black, little black cylinder. And it's ultrasounding the temples of this person right between these stickers with ultrasound jelly in between. It produces this great XY graph with the pulsatile wavelength. And there's a lot of secret sauce in just how the output is displayed that allows you to improve sensitivity for seeing bubbles, counting bubbles, and therefore grading shunts. And of course, it's easy to use. So at our hospital, where we are, resource efficient or trying to be, we've trained unit clerks or what we would call a secretary, medical office administrator, or MOA. So somebody that typically would be filing paperwork for you. We've trained them to set patients up in this while we get a history from the patient or get the IV ready. Of course, nurses have been trained at our hospital to use it and do it in the cath lab with Dr. Khan. And then echo techs. So this machine right now at our hospital lives in echo, and the echocardiography techs set patients up, and I come in and do the bubble studies during their workup. So ease of use, phenomenal support. We can text neurosignal questions. We typically get an answer back within seconds. There's a whole team of experienced TCD sonographers and technologists. that are kind of at our disposal, but also there's a physician community. So I can, call or text Tom Devlin or Jonathan Volpe, Houston Methodist, and typically get an answer within a few minutes, unless they're tied up with a patient. Another thing is when you're doing transesophageal echoes, it's challenging sometimes to get a good Valsalva or quantify your Valsalva. The NG2 has a very nice real-time feedback loop that tells you if the Valsalva is adequate or not. And of course, superior sensitivity. You've got bilateral simultaneous vascular windows. The display, the XY graph allows you to see the bubbles. There's also an audio hallmark. So if there's a bubble that you think you saw, you can go back and listen to it because there's a certain sound that comes with these as well. And of course, there's an NG2 robotic TCD community that started up that we all kind of message each other frequently, ask each other, what applications they're doing, what's their PFO protocol like, etc. So conclusions, I would say that in the real world, at our institution as well as others, the data for PFO detection and closure is very similar to the bubble study. In some centers, it's even better in terms of sensitivity of detection, sensitivity of grading, and sensitivity of TCD versus transesophageal echo. And of course, if we can save a person a transesophageal echo, if you've ever had one or seen one, can be a bit of an undertaking for patients and physicians. Razi may talk about a little case series we're developing where during PFO workup and then closure, patients are not getting any transesophageal echoes. So that's something that's come out of this as well. So we have boosted our detection and closure by more than 2.7. And I think it's only going to continue as we become even more efficient with our patient algorithm. And yeah, just like the Cult Classic Anchorman, when I was thinking about this talk, I thought, how phenomenal it is to have Dr. Khan and Neurosignal to collaborate with, because especially at a hospital like mine, you can't just do things yourself. You can't just do the same old rote workup and expect to make a difference. So you can't just read off the teleprompter. You have to find a way to, collaborate, but also stay classy. And I'll hand it over to Dr. Khan now.
Thank you. Thanks, Greg, for that great talk. Omar, do you mind just allowing me to bring up my slides?
Let me pull that off so nobody has a seizure. All right, let me know when you're ready, Dr. Khan.
Okay, anytime.
All right. There you go.
You guys can see the slides okay?
Yes.
Perfect. Okay, well, first of all, thank you very much, Greg, for that talk. And I will be talking about the importance of Greg's work, how fundamental he's been really in changing practice, how robotic-assisted TCD has changed the way that we approach PFO closure, as well as the importance of having a multidisciplinary team. I think that's really fundamental to treating these patients. So we already talked about who I was and who Greg is. The summary of the talk, or the main points, will be a discussion of some of the things Greg already talked about. We'll be talking about the screening of right to left shunting, or RLS, pre-PFO closure, comparing our data regarding robotic-assisted TCD with transthoracic echo and with TEE. We'll talk about how that's really changed our algorithm for PFO screening and closure. And then finally, we'll be talking about something a little bit novel. We'll be talking about how we use robotic-assisted TCD to assess residual shunting after PFO closure. So PFO screening. We published a meta-analysis a few years ago. This involved about 35 studies and about 4,000 patients. The studies were published anywhere from the mid-1970s to the early 2020s. And when we compared the sensitivity and specificity of standard transthoracic echo with the reference standard of TEE, we found that the sensitivity was about 73%. When we focused on more contemporary studies, so studies published after 1980, the sensitivity increased slightly to about 80%. When we focused in on patients who had high-risk PFO, so patients who would be ideal closure patients, those with large shunts, or the presence of an atrial septal aneurysm, TTE still had a sensitivity of only 74% in detecting right to left shunts. So we were missing about 1 out of 4 or 1 out of 5 patients in comparison with TEE. Given this absence or inability to detect right to left shunt, this sort of led to the advent of use of manual TCD in detecting right to left shunt. And Greg talked about this already. The sensitivity and specificity of TCD in comparison with TEE is excellent. He also talked about the cumbersome nature of manual TCD, how you require an experienced sonographer as well as an experienced neurologist to both do and interpret the study. He mentioned the Bubble study, which was a multi-center study looking at robotic-assisted TCD in assessment of right to left shunting in patients with cryptogenic stroke. And in that study, they noted both a 3-fold increased detection of all shunts, as well as a 2.5-fold increase in detection of large shunts. But I think what was really, really remarkable about this study was that the tests or the assessments done for robotic-assisted TCD were done by clinical research coordinators who'd had no training in TCD. They were given 1 to 2 hour tutorials, and despite that, only 7% of patients were deemed as having poor windows, leading to inadequate scans. So I think that's really remarkable. And I think because of that, because of its ease of use, Greg really pushed our foundation to get this technology. Over the last 18 to 20 months, we have done a protocol, a screening protocol, where we do simultaneous transthoracic echo with saline or bubbles, and subsequently a robotic-assisted TCD. So how does this look? Patients usually come in the morning, they get their IV line put in, they get their echo bubble study, and then they 20 minutes later get their robotic assisted TCD assessment. So it's basically a simultaneous assessment. Thus far, of the patients, we've had 55 patients who had a positive bubble study on TTE. And of those, 100%, so all 55, were noted to have right to left shunting on robotic TCD. So you had a sensitivity of 100% in these positive TTE assessed patients. Amongst those who had a negative TTE, about 2/3 of patients actually had a right to left shunt detected on TCD, and half of those patients with negative TTEs but positive TCDs actually had Spencer grade 3 shunting or more noted on TCD, so large shunts. So that's great. Those numbers are fantastic, but how does this really translate into clinical practice? How has this impacted PFO closure? So amongst those patients who had both TTE positive assessments as well as TCD positive assessments, almost all of them went on to PFO closure. So 53 of the 55 patients went on to PFO closure. We have one that's pending and one that turned down PFO closure but was offered for personal reasons. Amongst those patients that were missed by TTE and were detected by TCD, 3 of those patients have gone on to PFO closure, and we have 3 patients that are pending further assessment. So what do the guidelines tell us about diagnostic screening for PFO or right to left shunting? The guidelines, unfortunately, don't tell us very much. We have a number of different papers that offer expert opinions about potential algorithms to use for these young cryptogenic stroke patients. This is one such algorithm that was published in the American Heart Association journal. And so you have a patient who gets an initial TTE. They subsequently get a TEE. They're noted to have no or a low risk PFO. TCD is now introduced into the algorithm. These patients then are either diagnosed with no shunt or a high-grade shunt. They then get a repeat TEE or TTE. So some patients are now having a second TEE. If they are not detected, if a right to left shunt is not detected, then they don't undergo closure. And if it is, then PFO closure is performed. So this is a fairly convoluted algorithm and approach to these patients, something that's a little bit harder to use consistently. So our algorithm at the Royal Columbian Hospital, RCH, is, I think, a little bit more straightforward. And this is what we've implemented over the last year or so. So in those patients who have negative TTE and TCD assessments, those patients don't require closure. They don't need any further testing. They can go for other assessments of their cryptogenic stroke. The new part of the algorithm is that in patients who have negative TTE assessments with bubbles, but have large shunts noted on TCD, they are still able to get further testing, typically with a TEE. In those patients who have both a positive TTE and a positive TCD, these patients, remember, virtually always go on to closure. They're typically right now getting a TEE and then getting ICE-guided closure. But we're going to talk about how that part of the algorithm may change as well. So how has this really impacted closures? So as Greg mentioned, in 2022, before he got here, I was doing between, in the years before as well, 8 to 10 closures per year. In 2023, there was a slight pickup to 20 closures, and he started the program really in December of 2023. And since that period of time, we've had a steady escalation in the number of closures that we've been doing. And this year, for 2026, the projection is about 42 closures. So we've gone up about 4.5-fold since 2022. But even since he started the program, we've increased our numbers by about 50%. How does TCD compare to the traditional non-invasive reference standard of TEE for detection of right to left shunt in these cryptogenic stroke patients? Well, the first question that we should ask is TEE the gold standard, or should it be the true gold standard for detecting right to left shunts in these patients? When you compare it with invasive catheterization, so right heart catheterization, we know that there are false negative rates of about 8 to 10%. We know that when we do ICE catheter bubble assessments, ICE picks up about twofold the number of PFOs compared with TEE alone. We also know that there's a lot of inter-observer variability in detection of right to left shunting when doing TEEs. What is the primary limitation in these TE assessments? There are patient limitations, and then there are procedural limitations. So with regards to the patient, oftentimes these patients are sedated. They're getting a large probe put down their throat, which is natural. And so frequently they are unable to do Valsalva. As you can see in this study, this is a Valsalva assessment. This patient is unable to reproduce the septal bulge, so they likely do not have increased right atrial pressure, and therefore shunt detection is less ideal. The other factor which we often see is that patients often don't have complete opacification of their right atrium with bubbles. This is typically physician-related issue. But again, we see this commonly, and we know that this impacts our ability to detect right-to-left shunting in these patients. So when looking at our data, and there's hopefully a publication coming soon with regards to looking at this specifically, we have compared TCD directly with TEE. In patients who are TEE positive for right-to-left shunting, basically all of them have been noted to be TCD positive as well. So again, 100% sensitivity. In those who are TEE negative, we're picking up shunts in about 20 to 25% of patients. So 1 out of 5 to 1 out of 4 patients have some degree of right-to-left shunting noted on TCD that are missed on TEE. Given this, we've, over the last 3 months, developed a new protocol for obviating or removing the need for TEE in some patients. As I mentioned, in some patients who are both TCD positive and TTE positive, virtually all of them go on to PFO closure. So you can see this is one example of a patient who has a clear shunt noted on echo. And then on his Valsalva-based TCD assessment, you see this curtain effect with a lot of right-to-left shunting, a grade 5 shunt noted on TCD. So this was a patient that we actually closed in January. And again, thus far, we've done 3 patients. We have 1 more that's pending next month. So the algorithm on the top has changed, but it's also changed, or it is changing on the bottom. I have a bit of a translucent line. It's less firm, but I do see this being the standard for us. So for patients who have both a positive transthoracic study and a positive TCD assessment, they typically will not need a TEE. One of the questions that I've had when I've presented this to other interventional cardiologists is, how do you then gauge the PFO closure device size to use? I do all of my closures using ICE guidance. So with ICE, we're able to pick up the presence of an atrial septal aneurysm. We're able to look at tunnel length, tunnel width. And so if I need to use a larger device, a Gore 30 or an Amplatzer 30 or 35, I'm able to make that determination at the time of assessment, at the time of closure. What's relatively new is we also have a program where we do concurrent residual right-to-left shunting assessments after PFO closure. So Greg has been kind enough to actually come down to the lab while we're doing these PFO closures and do or interpret a lot of these TCDs. So when we look at robotic-assisted TCD versus ICE with saline, we note that about 80% of patients post-closure, immediately post-closure, still have some degree of right-to-left shunting in comparison to a quarter of patients using ICE alone. A third of these patients with residual shunting have significant or Spencer grade 3 shunting. We've also compared robotic-assisted TCD with echo anywhere from 3 to 4 months after procedure. This is standard. And again, they get a simultaneous TCD assessment as well as a TTE with bubbles. And again, quite surprisingly, we note that about 80% of patients still have some degree of right-to-left shunting. Again, about a third of them have significant Spencer grade 3 shunting or more, despite the fact that you would think that at this time point, the PFO closure device should be endothelialized. So is this important? We don't really know. We know that in patients with moderate to large residual shunting noted on echo, there is a correlation with recurrent TIA or stroke post-closure. But the prognostic significance of residual shunting based on TCD after closure remains unknown. This is a call to arms and a call to basically say that we need more centers assessing this to identify whether this is in fact prognostically important and whether we should be using either different devices or larger devices to ensure better closure for these patients. The other thing I wanted to emphasize, the last thing I wanted to emphasize, is that robotic TCD has really allowed for the democratization and increased utility of TCD. These are our two cath lab staff members. One is a nurse and one is a cardiovascular technician. Both have no training in ultrasonography. They both had a 1 2-hour training session done by the folks at NeuroSignal, and they have essentially been able to do these studies independently. Again, NeuroSignal provides great support if we need any assistance at any point. But again, these two staff members have essentially been independently doing these studies in the cath lab. The other thing to really, really emphasize, and I tried to find the best picture of Greg I could, was that it's really, really important to have the device, yes, but to collaborate with your stroke neurologist. The device does pick up increased shunting, but to get the, I think, most ideal treatment algorithms and treatment care for these patients, it's really important that neurologists and cardiologists interact and collaborate. So to summarize, for us, PFO detection has been greatly increased by a robotic-assisted TCD, and that has led to an increase in the rate of closures. It has led to reduced resource use, so reduced use of TEE, which is better for the hospital and for the patient having to go through these sorts of invasive assessments. We have noticed increased detection of right-to-left shunting after PFO closure, but we don't know really the significance of this, and hopefully you guys can help us in determining this. And I think the most important thing is not only is this technology really efficacious, but it's also super, super easy to use, and it can be replicated at any site. So that's it. Thank you.
Fantastic. Let me bring Robert up on stage. Wonderful presentation, guys. Robert, kind of take it away. We have quite a few questions in the comment section, so if people have a question, you can just drop in the comments. But Robert, I'll let you kind of take it from here.
Yeah, first, I just want to thank Dr. Khan and Dr. Walker for your incredible work and your teams, not only advocating for the field and pushing the science of PFO detection and understanding that, but really, more importantly, advocating for your patients. I can't imagine as a non-clinician how that must impact your workflow and the ability to treat those patients. So thank you for the time and effort that goes into this outside of your daily work. There are a large number of questions. I'm going to dive into it. The first is really around kind of that workflow argument, and I'm trying to combine a few questions here, is maybe Dr. Khan or Dr. Walker, for those negative TEE patients, how do you view those today? How do you think about continuing to work those up? Obviously, PFO closure is not for everyone. There's other things to be done there. But how do you think about it when you do have a positive TE or positive TCD and a negative TEE?
Sure. I mean, I think I talked about the limitations of TEE. So, we've had, I didn't talk about it, but we've had about 4 or 5 patients who had negative TEE thus far, but had both a positive TTE and a positive TCD. We've gone on to close those without too much difficulty. So I think that just underlies some of the limitations with regards to TEE, and it emphasizes the importance of not using that as a complete assessment. I think what's more complicated is that we do now have some patients that are TTE negative, that are having significant shunts noted on robotic assisted TCD, but then are TEE negative. I think in those patients, it's a little bit more complicated. We probably, in the next 6 months, for patients who have, say, grade 4 or 5 shunting on TCD, we probably are going to do an invasive assessment of those patients to see if, in fact, there is a TCD, if there is a PFO that's present, and whether it should be closed.
Just, yeah, I agree with everything Razi said. Just to add to that, these patients that are TCD positive with a large shunt, so 3 or larger, and a negative TEE, we have them in a separate database. We keep track of them. And the ones that we are planning to attempt closure or do invasive assessment with ICE in the interventional cardiology suite are ones that have a very compelling history. And so, to the stroke and neurology folks in the audience, at the end of the day, history and physical is still absolutely critical to getting the right workup for these patients. A lot of these patients that are TCD positive, TE negative, that we're planning on attempting closure invasive evaluation are, patients that were on a long flight, got off, went for a hike, the next day woke up, had a stroke, had a TIA. We were able to get records from those hospitals in other countries. Other ones are, post-operative patients that had an event. So the history is very compelling for a lot of these patients. So we felt, ethically, now that we have this ability with the robotic TCD to detect big shunts, that we are compelled to look further to really see if there's something there that needs to be closed. So history, physical, collaboration with cardiology, it kind of is the bedrock for all the answers.
Yeah, and that I think leads into the next question that, if you had combining this together and having talked to neurologists and cardiologists around the country and around the world, you, Dr. Walker and Dr. Khan, have formed a very tight relationship. And I don't see that at all hospitals. Can you talk a little bit about the history of that, the things that you wish you would have known beforehand in setting up this PFO clinic, and really that importance of that heart-brain team and that relationship between neurology and cardiology making these decisions?
Do you want to start, Greg, or?
You go ahead.
Okay. Yeah, I mean, it's essentially been fundamental for myself as an interventional cardiologist to have a stroke neurologist who's as interested in this specific field of stroke neurology. I showed you what our numbers were like before Greg arrived and what they've been like since. And in part, that's because of the technology that he's brought forth. But I think the other key component in this is that Greg is the person who sees the patient, who clinically assesses the patient, who determines if these patients should even be assessed in a more rigorous format. And so what I've noticed is not only are we doing, yes, robotic assisted TCD, but we are being more thorough in evaluating these patients. So sometimes they are requiring repeat assessments if the first ones haven't been done adequately. And so, I think that is sort of the most important part of having a PFO program, is that, in discussing these patients with him, we've seen not only is there a need for this technology, but there's a need for more rigorous assessment of these patients in general.
Yeah, I think there's opportunities for collaboration everywhere. I think a lot of sites, if they feel like collaboration's not easy, then maybe the perspective just the right perspective hasn't been found yet. I think fundamentally, Razi and I both care deeply about getting answers for patients. And that's why, NG2, the robotic TC has been so helpful, is because it's easy to use with patients. There's, kind of an answer they can see right away. I felt that, the cryptogenic stroke label and ESIS very unsatisfying. And I'd had a few patients in my career early on that, they'd had a cryptogenic stroke label, they were on anticoagulation, they came back, they were young, they had a repeat stroke. So, I felt very responsible to keep going. And then I think, finding Dr. Khan, he cares deeply about the quality of work he does and getting answers for patients too. And that's kind of why we've had so much fun collaborating, is because, we care, but now we're getting answers, and we're, decreasing the cryptogenic stroke label, which for a stroke neurologist is very satisfying.
Yeah, I can imagine from a patient perspective how frustrating that must be, not only for the patient but for you as clinicians, to really not have an answer for them right away, and to have some of that. I don't think it's something we speak enough about as an industry, of just giving that peace of mind. I mean, a lot of times, rightfully so, we resort to data and that, but I'm sure there's a great way to either qualitatively or quantitatively assess that peace of mind that you two are giving your patient population.
Well, you can imagine a young person, high functioning, has a stroke, comes to a big center to be evaluated, and they're told that at the end of the day, we don't know why you had a stroke. And now, they've got maybe 5 decades of life left, and they're worried every single day. So, it's disappointing for patients and physicians, but we're trying to cut into that disappointment with our collaboration.
Yeah. Some questions on use, and again, tying back to workflow and who does it. So a question around from a medical center in New York about they perform a large number of outpatient TCDs, non-robotic, so they do have the capabilities to do that. And looking at really the medical credentialing, or how you think about it from a British Columbia perspective of the use of your personnel and your team in either setting up the system and or pushing those bubbles. Because I do believe, Dr. Walker, you said you're pushing the bubbles, or how does that workflow, or how do you think about it from a hospital-based perspective?
Yeah, so in British Columbia, just because we are fee per service, meaning if we do something for a patient, we bill just for that service. So in British Columbia, if you are a neurologist doing bubble studies, you have to be present. That's what the fee code guide says. So I might as well push the bubbles, but I just have to be present. I know of other centers where they have a very robust manual TCD service, and then they get an NG2, and then the sonographers just do all the studies, and the neurologist reads them sometime later. I think the great thing about NG2 is it's so easy to use that really it can fit into pretty much any system. There's many different factors in how systems come to be at hospitals, remuneration, personnel available. We don't have sonographers for TCD. It's just myself that trained with manual. So I don't have that advantage, but it's quite easy to use pretty much anywhere. And it's portable, so we do it. I've done some inpatient, vasospasms common, done in the ICU, done it during interventional cases for carotid stenting and angioplasty, emboli monitoring, so I can push it into the neuroangio suite, and of course, intraops with Razi in his cath lab.
Makes sense. Yeah, and I think it's important for obviously the different clinicians in centers to understand, what works for them, what gets information, and from a credentialing standpoint, what makes sense for the individual states or the individual countries and provinces from that perspective. So another question: in a post-closure setting, what is the significance of a positive bubble test with TCD showing persistent RLS in terms of health insurance for future interventions? Further TEEs, second closures. So it really falls into that bucket of what does this data mean, Dr. Khan or Dr. Walker?
Yeah, so I mean, I think the simple answer is we don't know. We know that in patients who've had standard echo-based assessment of residual shunting, that if you have a moderate or a large shunt, there is some correlation with recurrent events. Our approach has essentially been to monitor patients at the time of procedure, at 90 days, and then at 1 year. So we now have some patients who are getting assessed at 1 year. Of the patients who've had residual shunts, we only have about, I think, 70 patients who've had assessment up to a year out. Nobody's had a residual event. But I think in terms of gauging prognosis, like I said, the important thing will be trying to get other centers and other sites to create a larger database, because event rates are already so low in the post PFO patient, in the post closure PFO patient. It's going to be very, very difficult for a single site to find adequacy in numbers with regards to getting an assessment of prognosis. The simple answer is that we don't know. Hopefully more sites can come on board, and we can create a larger database to see if it does correlate with future events. As to health insurance, I would say in Canada, that's not an issue. I would say in the United States, the argument against it impacting health insurance is that it's not currently standard of care, and we don't know the prognostic significance of these events. As to how health insurance companies view this, that's a whole other topic.
For a longer podcast, probably. But just wanted to thank you both again for the wonderful work that you're doing. And I know you both volunteered connections with neurologists or cardiologists or just community members that are interested in this topic to reach out to you guys individually and hopefully put together a nice database of that, Dr. Khan, to really take the next steps in understanding what is the role of PFO closure in helping reduce recurrent stroke. So I wanted to thank you again, Dr. Khan and Dr. Walker, for your work, for your patients, for the community, and thank you today.
Thank you.
Thanks.